so much on Zoom, right? There's no meetings yet on Zoom. So that's it's got to be different. To do a Zoom audience. Totally different. I can guarantee you that I mean, that's fine. I understand. I understand? Yes, I do understand. All right.
You got 1 minute.
Yeah.
Good luck. It's gonna be great.
So, welcome to everybody who is here, and particularly a good welcome to people by Zoom who, even this morning, I sent out a Zoom to our classmates who couldn't make it, and I hope that they are coming to hear this really exciting program. The class of 65 this is our fourth sponsored session of this type. I, with my leadership group, try to bring what we think is the most exciting work going on at Hopkins to the attention of this group. And I think we've done a pretty good job of that over the years. The class of 65 itself has been extraordinarily collegial. There are many people in it who have achieved leadership positions in American medicine, who have achieved leadership positions in law medicine and in clinical leadership. And they have been certainly a part of Hopkins. The class as a whole is coming close to $9 million of contribution over the years, and I even got a phone call from somebody who could not attend that for this anniversary, our 60th, the person is sending in a contribution to the scholarship fund of the class of 1965. So each of our speakers will have about 20 minutes to speak, and there'll be about 10 minutes for questions, a little bit less, so I can give lengthy introductions of each person and each program. So the first speaker today is Nestorius Mathadakis. Dr. Mathadakis is an associate professor in the endocrinology division of the Department of Medicine. He has an additional degree in bioinformatics, and he leads the clinical program in endocrinology and was, of course, a Hopkins Medical School graduate. So he will speak to us about the topic of AI and medical education. His interest is in both patient care and medical education, and I'm at least hoping that not only will he tell us that AI will help in educating physicians with quality, but I hope also that he will agree that something, maybe AI, can shorten the duration of training for truly expert physicians. I would just say from cardiology, which I know well, if you start medical school at age 22 and your goal is to replace aortic valves for the growing population of older people who need new aortic valves, that person will be 36 before they independently install their first aortic valve in a patient. So we're going to hear all about this, and I welcome you to Hot Talks.
Thank you so much for that kind introduction. It's great to be with you all. All right, let's see if I can get my slides up here. All right, so I am really excited to be discussing today a very hot topic in medicine, which is AI. I'm going to be talking about its applications in terms of training medical students, but also its role in clinical care. So AI is not something of the future. AI has definitely arrived in medicine. Whether it's helping to interpret radiology images, pathology slides, make a diagnosis off of ECG or EEG, or tracings, or even help with therapeutic decisions. AI is firmly embedded in medicine today. And in fact, as many of you have probably seen in publications, AI can outperform humans in some narrow tasks, like answering board-style questions. This figure on the right is the result of a query in PubMed of the term of a search of AI in medical education. And what you can see is that prior to 2019, there was really very little interest in the topic, a few papers per year. And then with these generative AI tools like GPT, which came out in 2020, and then GPT-4 in 2023, we've just seen this exponential growth in publications related to AI in medical education. And I think this really highlights how urgent and how relevant the conversation about AI in medical education has become. We're kind of at a crossroads here, like we were when that Flexner era report came in, which compels us, I think, to really rethink what the role is of a physician today. Now that we have AI tools that can, answer questions about treatment as well as we can. And so I just want to share with you a little bit about my role in advancing AI in medical education. As Dr. Weisfeld said, I'm the course co-director of our clinical informatics course. This is my second year doing this. And so last year, I literally had 4 weeks to assemble content in the curriculum related to AI. We were scrambling. And the first person to do something has, I think, the hardest job. And I will say that was not an easy task. Fortunately, this year, we have more structured material and sort of consensus in this field about what the core competencies should be in clinical informatics. And I'll share with you some of what we're teaching our medical students. I'm also involved in resident and fellow education. So I've created a training module, just a brief 10-minute training module of appropriate use of AI in the clinical settings. It's required of all incoming residents and fellows so that they know how to safely use these tools. A few months ago, I joined the Johns Hopkins Medicine Clinical AI Sub-Council. So this is an institutional governing body that was formed to help make decisions about what AI tools are appropriate for use within the institution before they're implemented, and how to monitor, more importantly, their use after deployment. And then my own research has largely used AI and machine learning using big data, so using electronic health record data for patients with diabetes. And I'm very interested in clinically evaluating AI tools. This is a space that there's very little evidence in. We evaluated an AI-based diabetes prevention program against standard of care human DPP, and we showed that it was comparable, and those results are coming out soon, hopefully in a pretty high-impact journal, fingers crossed. So, navigating generative AI in medical education. What I'd like to share with you, and I cannot cover this all in 20 minutes, so this will be a really high-level overview, is what I think are 6 core areas where Gen AI is shaping medical education, ranging from technical literacy to professionalism. We'll go through some of the challenges within each domain, and then I'll share with you what we think our proposed competencies are to prepare our students to use these tools responsibly, ethically, and effectively. Beginning with the first competency, which is fundamental knowledge of AI. So medical students come to Hopkins with varying backgrounds in computer science or statistics. Some may know what machine learning is, others may have never heard the term. And so we need to ensure that all medical students come out with a basic level of proficiency and fluency in what AI is, what ML is, what the subtypes of machine learning are, and how these large language models work, right? That there are a lot of misconceptions about what AI is and how it works, and students really need to understand that these large language models, these generative pre-trained transformers, are essentially taking vast amounts of data, breaking them down into these little tokens, assigning numbers to each of these tokens, and then using math to predict the next word. That this is all mathematics and probability, and that there is not this rational being behind these AI outputs. So that's the first really important point that they need to come away with. The other point is that a lot of these machine learning models are black box models, meaning that they use different computational techniques to arrive at an output for the students, but often they don't reveal which predictive factors for a given patient resulted in a recommendation, and how that can influence the physician's willingness to accept the output of that black box model. And then the third point is that the performance of these tools is highly dependent on the prompt quality. And actually, can I just see a show of hands of how many of you have entered anything into something like ChatGPT for an answer? Okay, good. So it's like the vast majority of this room. And so there's this concept called prompt engineering, where there's certain strategies that you can use for prompting to get the correct answer. And so we go through some of those principles with the students, and we show them how different prompts, just like the different quality of an HPI, for two physicians go in a room and get a different history from a patient and arrive at a different assessment, so can different prompts yield different quality outputs. So our proposed competencies are, number one, they need to know how these large language models are trained. Number two, they need to understand that the training data strongly influences the output of these Gen AI recommendations. We give an example from the dermatology space of an AI tool that gives automated detection of skin lesions. And these skin lesions were annotated by dermatologists who do not do as well on dark-skinned, in assessing skin lesions with dark-skinned patients compared to light-skinned. And so the output, as you might expect from these tools, had the same underperformance with dark-skinned individuals, and just how we're sort of propagating labeling errors or biases in our training data. And then again, we demonstrate how to effectively prompt to get the correct answer. All right, so then moving to the second competency, which is ethics and regulation. So these Gen AI tools are trained on massive amounts of data generated by human beings, so text, audio, video, and our biases are encoded in those training sets, and how that can influence the treatment choices or diagnoses that we make in medicine. We also introduce them to this concept from psychology called automation bias, which is how AI systems can influence our behavior in unpredictable ways. And so we know that these tools, as people begin to use them more and more, it can actually influence how much of their own clinical judgment they're using. They can become overly reliant on the tools, especially where the queries are complex. So it's a complicated history. There's a lot of data inputs. The output of these things are incredibly believable. They seem like a human being. They read like a doctor. They seem believable, and you start to trust them more than your own clinical judgment, and that can be dangerous. That's the concept of automation bias. The other point that we emphasize is that the pathway for regulation for these AI tools is really different than the traditional drug approval pathway that the FDA had used for decades. There's some, the FDA is weighing in on this to make it a little easier for these to come to market, but many of the tools that are actually available today did not go through any rigorous regulatory pathway, and there's a concern for safety as a result of that lack of oversight. And then finally, this concept of fair use of data. Can we use patients' data from the electronic medical record to continue to innovate and generate AI algorithms? Is that fair, and do we need to disclose that to our patients? So the proposed competencies here are evaluating these ongoing debates on Gen AI regulation. We try to explain how biases can be encoded in the data, and this is evolving rapidly. So we go through some perspective articles from the New England Journal of Medicine AI on debates about sort of issues like fair use of data and training. Moving to the third competency, which is I think the most exciting one, which is application to clinical care. So if you haven't seen the NEJM AI journal, I would encourage you to check that out. It came out in January of 2024, so it's been out for about almost a year and a half now, and they publish really rigorous RCTs of AI interventions. So you get to see really the cream of the top of the studies coming out in this area. So we are already seeing AI being used in ambient listening, so virtual scribes, and clinical documentation and patient communication. I, for one, think that this is one of the greatest enhancements that has been made to restore the joy of medicine in the last 20 years that I've been practicing here. This Abridge virtual scribe has absolutely changed my quality of life. So I'm a diabetes specialist. I have a ton of data to capture during a visit from a patient. My hands are completely off of the keyboard. My face is turned to the patient. I'm interacting with the patient. I'm picking up things that I could not have because my eyes are actually on them. And I'm using the EMR in the way that I think it was intended to be used, which is to get the historical information I need, identify care gaps, and get them on the right treatment. So I think an absolute game changer. Some studies would suggest that we're overinflating the value of these tools in terms of clinician efficiency. The other big area is in empathy and the empathetic capabilities of Gen AI tools. You may have seen a study that was published in JAMA Internal Medicine in 2023 showing that patients perceive Gen AI generated responses to their questions to be more empathetic than physicians. This was a randomized study, much more empathetic. And that probably comes as no surprise. We have time constraints. We cannot spend 5 minutes elaborating on something. And so, the thought is here that it's just the ability to do this much faster and provide more detail that the patients are perceiving as more empathetic. And then there's value in the AI tools in helping to take a history, take the history in real time. So you're having a conversation with the patient, they're bringing up a point, you ask a question, you forget to ask a question, the AI supports you, you gather the information, and it's this iterative process. And same thing goes for personalized decision support and management. So a lot of applications all across medicine, some really exciting stuff being done in clinical care. And the competencies here are not only using Gen AI to make sure that we're communicating in an empathetic way to patients, but actually using it for teaching, so simulation. We can have students interact with ChatGPT and delivering bad news to a patient and seeing how that dialogue goes. And so providing that real-time support to them. The Master Adaptive Learner Framework is a framework that's applied in medical education pre-AI, and it's the idea that we are always, as physicians, going to be exposed to new treatments, new technologies, things that we are not familiar with. And this is a lifelong learning process. So we need to know how to self-regulate. We should try these tools out, assess how we do, assess how it does, and adapt continuously. And if they're not working well, as a collective body, we need to remove them from the care paradigm. And then the last point is sort of this existential question of how will Gen AI alter clinician roles, right? And it will. So, you know, the AI can do better at answering the question or even making the diagnosis. So what is our place here? And so clearly we're going to need to shift from, you know, being these sort of like the physician as the repository of knowledge to being more of an information curator, someone who can critically appraise the evidence, can ethically guide the use of this evidence, and can use their clinical intuition combined with the patient's value, their values, and their emotional response to get the best outcome. This is a tool. We don't think this is going to replace clinicians entirely. Patients are telling us that they still value the face-to-face interaction with clinicians, and they, when told actually whether an output was AI versus human, even if the output was a lower quality, but they were told it came from a physician, they wanted the physician endorsement. So patients still trust and value the human involvement in decision-making here. All right, assessing AI quality and accuracy. I think this is a really, really important concept that they need to come away with a good understanding of. As if I saw a lot of hands go up, so anybody who's used these tools knows that they are prone to hallucinations, which is, you know, fabrications of incorrect, irrelevant, or sometimes frankly bizarre output that has nothing to do with what you've asked. And you know, it's one thing if that's the answer you get for your English essay. It's another thing if that's an answer you get for how do I treat Mr. Jones with, you know, leukemia. And so really important patient safety implications with these hallucinations. So they need to know that they occur, why they occur, and how to identify that they occur. The second concept is the model drift over time. So unlike a drug, which, you know, if tested in 2018 will likely work in the same way in 2028, an AI algorithm developed today may not perform as well in 2028 because of secular trends. So changes in treatment protocols, changes in disease states can really influence how a model performs over the long term. One example was in the sepsis space. So there's a lot of machine learning models to predict clinical deterioration in sepsis. And models made prior to 2018 really performed poorly in 2019 and 2020 because of COVID, right? So there's a new disease state with a new rate of mortality that really influenced how these models performed. And that can happen with any AI model. And then the third point is, despite all of this hype around AI, the vast majority of these interventions have not been externally validated, that is, tested on a population different than the population that was used to make the model. They have not been prospectively evaluated, right? Nor have they been tested in randomized controlled trials. So less than 5% have been tested in RCTs. So we need more rigorous evidence of these technologies, and we need prospective evaluations before we can be confident that they're doing what they claim to do. So these are the proposed competencies in this area. Hallucinations, critically appraising these outputs, and developing a strategy, and this is usually at the institutional level, for monitoring how they perform over time. Very briefly, data privacy and security. Anything that anyone enters into one of these commercial AI tools is not HIPAA compliant. So if a student were to enter into ChatGPT, Ms. Smith, a 52-year-old woman with X, Y, or Z, has here with this, and I need help with this, that is a breach of patient privacy. There have been instances where the information entered into ChatGPT actually came out of somebody else's query, right? So it was used to train the data, and actually it was breached in that way. As a result of this, many medical centers, Hopkins included, have launched their own instances of large language models. And it's now recommended that and these are HIPAA compliant, so you actually can put PHI in them. If you're going to use it, you've got to use the Hopkins approved version. Okay, professionalism, and this is the last competency. Right, this is a hard topic to cover. I mean, I don't know the answer to this. None of us knows exactly how this is going to change, what it means, the core role of what it means to be a physician. But we're getting students to think through what are tasks that are likely to be, that we're currently doing that will be replaced, right? Which face-to-face skills are unlikely to be replaced by Gen AI based on what we're hearing from patients currently. And in light of what AI can do, what is our contribution to patient care? So we're talking a lot about etiquette and appropriateness of Gen AI in healthcare and patient communication. Would it be appropriate to use ChatGPT to write a condolence letter to a patient? Would it be appropriate to use ChatGPT to deliver bad news in writing to a patient? If the patient can tell that ChatGPT generated that, how would they feel? You know, that is likely to be perceived as impersonal. And so we're really emphasizing this, that upholding this sort of same level of professionalism as they would use in a face-to-face interaction. Very briefly, because I know that I'm coming up on my time, Hopkins has these governance policies here. They have all of these AI-approved tools where they direct, this URL is a little outdated because they just updated it this week, but we have our AI instance. It's called the Hopkins AI Lab, HIPAA compliant, as I mentioned. And I mentioned earlier the CRAP test, which is from sort of library science and information science, as a way to validate the output of any ChatGPT generated content. Is that information current? Is it relevant to the clinical question? Who created the content? Is there a medical study that I can cite? Is there a guideline? Is it accurate based on the evidence? And purpose is less relevant here, but why was the information created? Open Evidence is a really neat platform. If you haven't seen it, you can put, and they say that they're HIPAA compliant, although it's not Hopkins approved. You can put in the query. It will generate, let me show you this. This is pretty neat. It'll generate the output. So I asked a question about a middle-aged man with type 2 diabetes. Which drug should I do next? And it shows you a recommendation, but it importantly provides the reference to support each claim that it makes. So you can actually directly validate the output of that. All right, so in conclusion, you know, this is not the future, this is now. We are at an important paradigm shift. We have to adapt medical education accordingly. Some of the priorities that I mentioned are having clear policies and governance, training both our students, our residents, and our faculty in this area, and defining core competencies, and they'll likely change next year. We do have challenges, and we're going to need to collaborate as a profession across institutions to come up with best practices, I think, in this area. So with that, I thank you for your attention, and I don't know if there's time for questions. Yep.
Going back to William Osler's day, you could get paid for the quality of the care you deliver. One of the ways if we're going to improve quality of care is we compensate physicians for their outcomes and quality rather than quantity.
Yeah.
How soon do you foresee we're going to be able to take patients with lupus, for example, take 2 cases, adjudicate their severity of illness, and then use the outcome of each patient that the physician has to determine part of their compensation down the road?
Yeah, that's a great question about, so is the reimbursement model that we currently use appropriate, or should we shift towards a pay for quality or pay for performance? That's a huge question, bigger than AI, and not sure that I can answer that intelligently. I think there are some instances where that is being applied, right? Like incentivizing hospitals or health systems that have better outcomes for condition X, Y, or Z to get paid more. There are also concerns about fairness of applying the pay for performance standard equally. So let me give you an example. I take care of patients with type 2 diabetes. Many of my patients come from East Baltimore. They have numerous social determinant barriers, socioeconomic barriers. Glycemic control is much, much harder to achieve in those patients. If I wanted better outcomes, I could preferentially not see those patients and see patients who I know I could get the outcomes for. And that sort of goes against the Hippocratic Oath. So there's this like tug of war between incentivizing for performance and just making sure that everybody gets the care that they deserve.
Question.
Yep.
Why is it so hard to fact check? Going back to the hallucinations
Yeah.
and going back to your last example where
Yeah.
references are given,
Yeah.
the legal history is that those references are sometimes hallucinations themselves.
Yes.
And so the question is, why is it hard to build a fact checker into the output of your system?
It's a great question. There actually have been some studies looking at using ChatGPT to fact check itself, and it does pretty well at catching its own mistakes, interestingly. With each enhanced version of this, the hallucinations have gone down. Generally, the references to fake articles is also going down, but why that happens is unclear. These tools like Open Evidence, they make it really easy to fact check. You're not going to get a false citation there. You've got the link. But ChatGPT, I used it today. I used ChatGPT 4 and I compared it to Open Evidence. It generated really believable content and it gave me a wrong PubMed ID and citation again. So it's still happening. And the fear is that you get a reference and it looks like a believable reference, so you don't think there could be a chance that it's citing something wrong and you don't take the time to check it.
So don't you think that as the history and physical examination use of AI advances, that they will not put into it what additional information would be helpful in this patient? Leading, of course, to what I
Yeah.
commented on.
Yeah.
Could we evaluate in a much better way the performance of patients,
Yeah.
doctors, and their advancement into sophisticated physicians?
Yeah, no, I to your point earlier about accelerating the pace of training, I think there is a huge opportunity. Yeah, and I think that some have suggested that patients will first engage with a robot that will get the history and do the initial workup, and then phase 2 is that you see the human being and get the exam, and right. I think for procedural skills, I mean, I'm not a proceduralist. I think you need time doing the procedure. That's the most important thing. And I don't know that we can replace that with AI.
Okay, we need to go
We'll go,
on.
yep, okay.
so
Thank you
much.
so much.
Wonderful. Okay, Robert Brodsky is the Johns Hopkins Family Professor of Medicine, a story in and of itself, I would tell you. Yeah, but it's a great honor and the right honor for Dr. Brodsky. He is the head of the hematology division long-term within the Department of Medicine. He went to medical school at Drexel and trained in research at Vanderbilt and a long period of productive work at the NIH, and then came to hematology oncology here at Hopkins, and I had the honor of appointing him to be the division chief, one of my best acts as chair of medicine. Dr. Brodsky is going to speak to us today about sickle cell anemia, the issue being sickle cell, curing sickle cell anemia, which I think everybody in America, and particularly everybody in Baltimore, would love to see accomplished. Dr. Brodsky.
Thank you. And let me just get to the start of this. Okay. There we go. Perfect. Thank you. And I would just like to say what an honor it was to be in the Department of Medicine under Dr. Weisfeld, who really took an amazing division and made it even, amazing department and made it even stronger. So it was a great honor for me as well. So I want to talk to you about sickle cell anemia that many of you probably don't think of as a curable disease, but it turns out is incredibly curable right now. A couple Tuesdays ago, I had 4 cured sickle cell patients in my follow-up clinic in one morning. So that should tell you how things are changing. Just to remind everyone about sickle cell anemia, again, I think you learned that even ChatGPT will probably get this right. This is a single base pair mutation. It's in the beta globin gene. And what happens is it causes red cells to polymerize and form this stiffened shape and get stuck in the blood vessels and cause incredible vaso-occlusive pain and end organ damage and shortens lifespan. The median survival of a patient with sickle cell disease today without curative approaches is still in the 40s, mid-40s. And even before that time, the quality of life for most adults with sickle cell disease is very poor, that many of them are unable to finish school or hold a job. So I'm going to talk to you about 3 curative approaches, 2 that have gotten incredible attention because they're coming from drug companies, and 1 that doesn't get a lot of attention because it's coming from academics. But it's the one that is coming from academics that is really changing the landscape. So you've heard about gene therapy. It's all over the news. And so how is this done? So on the top, which you can see, I don't know if there's a way I can use a pointer, but, oh yeah, okay. All right, so what they do here is they take the sickle cell patient and they take out the patient's peripheral blood stem cells or bone marrow, usually now peripheral blood stem cells, and they put a gene in using a retrovirus. And what they do is they put the normal beta globin gene in. Then the patient undergoes myeloablative, very, very high dose chemotherapy to completely wipe out their bone marrow. And then they give these autologous cells back to the patient. And this has been done now in over 50 patients. There is another approach where it starts out the same. They collect the stem cells, but here they use CRISPR-Cas9 to actually knock out a gene called BCL11A. And what that does is it's very important in hemoglobin switching. So you remember from going from fetal to adult hemoglobin, you go from gamma chains to beta chains. So hemoglobin has 2 alpha chains and 2 beta chains. Adult hemoglobin, sickle cell disease is on the beta chain. So if you prevent the switch and you just make fetal hemoglobin 2 alpha chains and 2 gamma chains, then you won't sickle anymore. So it's pretty ingenious that way, and then it's given back to the patient, and this has had some efficacy as well. The other approach, and the initial approach to cure patients with sickle cell disease was bone marrow transplant. But traditionally, that required a perfectly matched brother or sister. This is where you take a sickle cell patient and you give stem cells after some chemotherapy from a healthy donor. And because those healthy stem cells don't have sickle cell or have sickle cell trait, if it's a family member, they don't sickle anymore, and you can cure the disease that way. So let me walk you through these. Been several New England Journal articles. This is biologic and clinical efficacy of lentiglobin. This is replacing the beta globin gene for patients with sickle cell disease. And what you can see here is the number, these red and blue things are sickle cell pain crises before and after the gene therapy. And what you can see is that most of the patients, not all of them, but most of the patients have eliminated their vaso-occlusive crises. Their hemoglobin doesn't come up quite to normal. But again, this is showing promise. The problem has been many of these patients will develop leukemia later because you're giving myeloablative conditioning, and several of the early patients, when they got out around 5-6 years, have developed myelodysplastic syndromes and leukemia. Similar results with the CRISPR, where this is the one where they're knocking out the BCL11, causing the switch. Again, the data look good. Most of the patients are able to markedly reduce their pain crises. And many of these patients may be cured from this approach. But the hype on the gene therapy and the gene editing is fading, and for multiple reasons. One, it's incredibly involved. It takes months and months of transfusions and collections just to collect enough stem cells to be able to do this. And the cost of this is enormous. They are charging over $3 million per patient for these treatments. The other thing is, as I told you, they have to use what's called myeloablative conditioning. So that's massive doses of chemotherapy. Patients with very severe sickle cell disease can't tolerate myeloablative conditioning because of their end organ damage. So they're having to exclude patients who have stroke or silent cerebral infarcts, which is one of the leading indications for transplant. If you have some lung issues, which many of our sickle cell patients do, you're excluded. Kidneys, you're excluded. Liver, et cetera. So a lot of patients are missed by this approach. The other thing is the length of hospital stay is about 2 months for these patients. It's very, very much involved. And then I talked to you about the risk of leukemias that come out later. Let me talk to you about bone marrow transplant and the advances that have taken place there, because when you were going through medical school here, you were going through a very interesting time, and I'm sure you remember some of this. Bone marrow transplant doesn't look anything like what it looked like back when you were in medical school or residency. So the first cure for sickle cell disease was in a patient with sickle cell disease who developed leukemia and then had a bone marrow transplant, and they were cured of not only the leukemia, but also the sickle cell disease. Now, the problem is that the rates of graft failure were high in the early days of transplant. And as I said, it's been up until about 15, 20 years ago, you always needed a perfectly matched brother or sister in order to have a safe bone marrow transplant. That's no longer true, as I will show you. And then in order to get the graft in, way back, you also needed myeloablative. We can now put stem cells in without a myeloablative, something we call non-myeloablative or reduced intensity conditioning. Anyone remember these guys? See if you can. So, you talk about some of this cutting edge stuff, but it's very important, and hopefully AI will get this in there too, is to remember our predecessors who really helped form the foundation. That's George Santos. George Santos is one of the largest pioneers in bone marrow transplantation. This is Al Owens. These two basically started the field of oncology and started the bone marrow transplant program and oncology out of Baltimore City Hospital, what's now known as Bayview. This is Mike Colvin, who was an expert on cyclophosphamide. He did a lot of clinical pharmacology. And this is Lyle Sensenbrenner, who also worked with George a lot in bone marrow transplantation. So I mentioned cyclophosphamide because this is a critical drug that has allowed us to do what we call haploidentical bone marrow transplant. We no longer need a matched sibling. We can use almost any family donor. So any parent, any child is guaranteed to share one haplotype. 50% of your siblings, 50% of your half-siblings will share a haplotype. Many of your cousins, nephews, nieces, we've used grandparents as donors. The reason that this works, and I'm going to simplify it, stem cells are resistant to cyclophosphamide. So what happens is we give the high doses of cyclophosphamide after the bone marrow transplant. The two immune systems meet. The alloreactive cells are wiped out by the cyclophosphamide. The stem cells aren't. And the stem cells are re-educated by the patient's own thymus and immune system, and they become tolerant. So the average person in the United States has 4 haploidentical donors, so almost everyone now has a suitable donor for a bone marrow transplant, and the results with half-match transplants are now as good as if you had a perfect match. The first successful haploidentical bone marrow transplant for sickle cell disease was done here at Johns Hopkins in 2007. This was a 33-year-old female. She was spending about 3 weeks out of every month either in the hospital or an infusion center getting pain medicine, had a horrible quality of life. Her mom was the donor, and she is now 18 years out of her sickle cell disease and I don't think she's been in the hospital since. This has been now replicated in a national trial at 19 centers. This just came out in New England Journal of Medicine Evidence several months ago, showing the overall survival here of 95%, an event-free survival, meaning engraftment, so the patients are alive without sickle cell disease, 88% using half-match donors. And we've even improved upon that. That came out, like I said, about 6 months ago, but we're submitting a paper. It's already under review, where we're making even further advances, because all of the regimens that I just showed you, whether it be gene therapy, gene editing, or the bone marrow transplant that I just showed you in this paper, those patients become infertile. And that's a big issue to sickle cell patients. This is a regimen that we've been using here. We modified the radiation dose, and we've been able to shorten the immunosuppression, and the results have just been incredible. We have 5-year overall survival of 95%. There was no transplant-related mortality. There was 2 late deaths, one from an accidental drug overdose and one from a suicide. We have 5-year disease-free survival, meaning alive, even including these late deaths, without sickle cell disease of 94%. Graft versus host disease, you remember, hearing and seeing about that. Well, grade 2 is usually just a mild skin rash that we sometimes don't even treat, or sometimes throw people on steroids for 2 or 3 weeks. That's not a big deal. It's grade 3 and grade 4 that we worry about more. Only 2% of the patients had grade 3 GVH, no grade 4. And that patient is fine as well. So these are curative options now for sickle cell disease. We have the gene therapy, we have the gene editing, and then we have the bone marrow transplant approaches, one with a drug called Thiotepa that's myeloablative, one with the revised Hopkins approach, which is, doesn't cause infertility. But look at the costs of these. They're charging $3.3 million, $2.2 million, and then when you factor in the 2-month hospital stay, that's another cost, because you got to have multiple patients in the rooms. So the results are actually probably better with the transplant approaches than the gene therapy and gene editing. It's certainly more cost efficient, and Now we can say we can preserve fertility. And this is going to really allow us to bend the curve. So I want you to think about how this could be used. So we would like to start an initiative to try and really, not eradicate, but effectively eradicate severe sickle cell disease in the region. In the state of Maryland, there's about 3,000 patients with severe sickle cell disease, or with sickle cell disease, but only 500 to 600 have the severe form of the disease. In our region, we follow at Johns Hopkins about 600-700 patients, and only about 125 or 150 of them have the very severe form of the disease that would require bone marrow transplant or gene therapy. So you can imagine if we started doing 35, 40 transplants a year for sickle cell disease, which is not hard, we're already up around 15 to 20 now, we can really bend this curve quickly. And the impact on health and care would be enormous. So I'll give you some amazing stats. This is the largest user of blood of any hospital in the nation. 36,000 units of blood come to Johns Hopkins from the Red Cross a year. Sickle cell patients use 12,000 of that. Patients who are with severe sickle cell disease are frequently on chronic exchange transfusions. That means they're getting exchanges, blood volume's taken off, new blood's putting in, 8 units every 4 weeks. That's 100 units a year in one patient. Just imagine if you took those 125 patients that were on chronic exchanges and transplanted 60 of them. The impact that that would have on not only the patients, but also blood supply, cost, emergency room visits, hospital stays, et cetera. So we're currently screening about 2 to 4 patients a month, and we're going to get to these numbers, and it's just getting the word out more and making sure that we get referrals earlier so that we can get these patients and to stop have such a horrible life. So I'll stop there and take any questions.
How many days average hospitalization?
Yeah, so it's a great, that's the other thing. Thanks for asking. We do this mainly as an outpatient right now. So we'll admit the patient prophylactically because usually when you give them chemotherapy, they're going to have a pain crisis. So we like to get ahead of that. Once we get them through their pain crisis, which is usually 3, 4, 5 days, we send them out. When I say outpatient, it's a day hospital, so they come in every day and to be seen. So the median number of hospital days for an adult with sickle cell disease is 12. And actually, after the transplant, the median number of transfused units is 3.
Dr. Zizek?
I'd like to applaud your magnificent work. I'm very curious on your strategy, and I'm sure it's important, but I'm not understanding it. I noticed in your first ablative dose, you're using 14.5 milligrams per kilogram IV daily. In the second ablative dose, it was 50 milligrams
Yeah.
IV. Could you explain?
Yes.
I'm not getting it.
So the conditioning regimen that we use is really more immunosuppressive rather than to myeloablate. We just need to suppress the immune systems to allow the stem cells to get in. To put it in perspective, if I took that dose of conditioning, I wouldn't even need a blood transfusion. My counts would dip a little bit. I might become a little anemic. I might drop my platelet count to 60,000, but I wouldn't need any support. What allows us to do the haplos is the 50 times 2 afterwards. So what happens here is the donor lymphocytes see the host dendritic cells. We worked this out in animal models. At day 3 and day 4, is when they are dividing the most. That's when alkylators are best killing. So when the cells are dividing. So when the donor lymphocytes, which that's what causes all the toxicity from bone marrow transplant, see the host dendritic cells, they see it as foreign, they start rapidly dividing, bang. You hit them with Cytoxan, you knock out the lymphocytes, but you don't harm the donor stem cells. This is what George did, Santos, in his animal models. And he never had the courage, and he told me this personally, to do this in a human. He knew about this before he passed. And he said, I knew this would work. But that's why I really wanted to show that our predecessors really worked this out. Yes.
So to turn the insurance company and the government, Medicare and Medicaid onto this, how much savings did you estimate or could you estimate in the healthcare costs of the
Yeah.
patients you've treated?
So great question, and we actually, you'll love this. We have our medical economics
Yes.
at Bloomberg working on this with us.
Terrific.
And one of our fellows who's an MBA, and we are actually going to present an abstract probably at the American Society of Hematology this year, but it's looking like the break-even rate time point is going to be about 2 years from what their cost of care was per year for the first, for the few years before the transplant. It's about $105,000 a year, so $280,000, you're going to break even at 2 to 3 years.
Dr. Kelly?
Thank you. Yep.
It seems like a very general approach. I'm wondering whether other genetic diseases, this kind of approach could be used. I'm pushing.
Yeah, I can repeat the question. So the question is that this is can this be used for other diseases? And yes, I have a patient from the south up there right now that I was visiting before I came over here with severe aplastic anemia. And he's undergoing the same procedure. It's transformed that. But you really want to get excited. So one of the things that we're starting to do, and we're going to evaluate a sickle cell patient for this, is organ transplants. What? So if you're giving a living related kidney, if they share a haplotype, you can use that same person who gave the kidney as a bone marrow donor. Then the kidney and the immune system match, and you don't need long-term immunosuppression. So there are lots of disorders that yes, are.
Dr. Hirschman?
Sickle cell patients don't require immunosuppression.
Sorry.
So we stopped the immunosuppression on all of these patients at 6 months. They're on nothing.
Dr. Hirschman, last question.
Great question. So it's
What's the question?
the question is, what age do you do this? And it really depends on the patient and the severity. We do some kids, but we don't do a lot of kids. And the reason being is the current therapies that exist, very few pediatric patients die of sickle cell disease anymore if they're cared for well. The group that we'll do in the pediatric group is if they're having strokes, in spite of, so if they're having silent or overt infarcts, we will take them to transplant. Most of our patients are in their 20s to late 20s, 30s, in that range, because that's when they start to accrue some of the end organ damage, and we're taking them. But I can anticipate your question. Yes, why not do it earlier? And again, this is still a big procedure. This still has risks. It's getting safer and safer, but like any other disease that we did with bone marrow transplant, we usually start with late stage, and as we do more and more, we move it up, and we will.
Thank you so much, Robert.
Yep.
Terrific. So this is a little bit unusual state of a project to be presenting to you, but it is certainly not unusual that this is a Hopkins project that conceivably has enormous health benefits for many people. And it comes right out of our teaching education program. Anders Sedaris is a graduate of University of Newcastle. Received his medical training degree there in the British system, and is trained in otolaryngological surgery as well in Australia, and came to Johns Hopkins to participate in the School of Engineering master's program in engineering, along with a colleague, Dr. Michael Turley, who unfortunately couldn't be here today, but participated significantly as a master's student in the School of Engineering in this project. So I think all of you have seen the commercial on television for an implanted device with an electrode to prevent patients from snoring. Snoring is a significant problem, right, Linda? And it has a significantly adverse effect on not just socialization, but on human health. And obviously, this is a procedure, implantation. Dr. Sedaris will talk to you a little bit about the problems with that procedure. But he has what we really hope, and this is, again, a developmental project to see if we can accomplish the same goal or better with a device that is less invasive. Dr. Sedaris.
Thank you. Great. Fantastic. Well, thank you so much to everyone for being here today, and thank you, Dr. Weisfeld, for having me. It really is a privilege to be here today and speak to multiple alumni groups from Johns Hopkins Medicine, one of the leading medical schools in America and around the world. My name is Anders Sedaris. Dr. Weisfeld gave a very kind introduction. I'm from Australia. I'm a doctor by training and an engineer and a medical device innovator. My talk today will be about our newly formed company that's spinning out of Johns Hopkins called Somnair. At Somnair, our mission is to bring an end to invasive and ineffective treatments for obstructive sleep apnea. We're a project and now a company that is spun out of the Johns Hopkins Center for Bioengineering, Innovation and Design, which is a mouthful. We sit between the School of Medicine and the School of Biomedical Engineering. And really the great thing about this program and the projects that we do at this center is that we have a mission to marry the brains and the minds of medicine and engineering and business to bring everyone, all those people's competencies together to bring medical device innovations that can change the face of human health and actually get them to market so that patients can use them and doctors like yourselves can prescribe them or implant them or whatever it may be. Obstructive sleep apnea is a growing global epidemic. So there was an article published in The Lancet in 2019 that estimated that the global prevalence of OSA is 1 billion people around the world, which is quite astounding because that's 1 in 8 people. Now that equates to approximately 54 million Americans with the disease. It has not only does it have a huge medical cost for the patient, but it has a huge health economic cost. And those are related to a 2 to 3 times higher risk of having a stroke, a heart attack, developing metabolic conditions such as diabetes related to circadian metabolic dysfunction, debilitating daytime sleepiness, people crash their cars because they fall asleep at the wheel. And on top of that, there's the social disturbance that Dr. Weisfeld spoke about, which we, in the clinic and in my training in ENT surgery, was all too common. And the joke we used to say is that 100% of dads end up with sleep apnea. So it's a disease that's characterized by the upper airway collapsing and obstructing repeatedly during sleep. And the fundamental issue in this is that between the awake and the sleeping state is that when you go to sleep, there is a reduction in neuromuscular tone in the muscles of the airway. So neurostimulation as a concept aims to treat this disease by restoring that tone in the relevant muscles to prevent the airway from collapsing by stiffening or opening the aperture of the airway. It's a huge public health problem, as we've mentioned. So right now there are 8 million patients in the US with CPAP that's been diagnosed. The remaining between the 54 million and the 8 million are undiagnosed sleep apnea patients. 50% of patients will fail CPAP therapy because it's uncomfortable, it's bulky, it's difficult to take on holiday, it's not portable, and quite frankly, it's not the sexiest thing to sleep with at night. So there's this huge unmet need that sits between CPAP and surgical techniques. So in ENT, we see patients who have failed their CPAP therapy and they come begging for surgical solutions. One of those solutions that Dr. Weisfeld spoke about is Inspire, which is a hypoglossal nerve stimulation device which is implanted. It requires a dissection in the neck. We dissect down to the hypoglossal nerve, which is the nerve that provides motor innervation to the tongue. And we put an implant on it and it stimulates that nerve and pushes the tongue literally out of the airway repeatedly during sleep. These guys have had immense commercial success because the need is there. But there's still problems with this. Namely, not all obstructive sleep apnea patients have airway collapse at the level of the tongue. So there are other anatomical structures, the palate, the lateral wall or the side walls of the throat, or the lateral walls of the pharynx, which are actually more common in causing airflow obstruction than the tongue is. The tongue has just been that one target that it has been the easiest surgically to get to, hence the development of the technology around that target. Our hypothesis in this project was that we could stimulate different neuroanatomy to produce airway opening effects in a different patient population to prevent the disease, or to treat the disease rather. So there is a nerve which is a branch of the maxillary division of the trigeminal nerve called the lesser palatine nerve. Now, when we're going through medical school and we learn how to do the cranial nerve exam, we're all taught the dogma that the pharynx is supplied by the pharyngeal plexus, a combination of the vagus and the glossopharyngeal nerve. Deep down in the literature are some really cool studies that have been done that characterize the finer innervation of the palatal and the side wall, the lateral pharyngeal wall anatomy, looking at the lesser palatine nerve itself. It's been demonstrated that it has motor innervation to these muscles, despite the dogma saying that the trigeminal nerve is primarily a sensory nerve. So our hypothesis was that if we could stimulate this target, we could open the palatal and pharyngeal airway to prevent the airway from obstructing and potentially be a treatment for obstructive sleep apnea. The culmination of the device that's intended to stimulate this nerve is the Somnair device. So this is our vision, an oral appliance, something similar to Invisalign, which has an electronics module embedded into it. The electrodes interface with the mucosa that sits below the lesser palatine nerve, transfers current across the mucosa to the nerve, stimulates that nerve, activates those muscles, and opens the airway. So this is an exploded engineering diagram of that. And the proposed benefits are that we can do this non-invasively, so we don't need surgery. It can be prescribed by the clinician in their office, and the patient just deploys it nightly at home. And that's what it would look like once it's assembled. Our journey towards defining whether this could be a target and whether this could be a viable therapy was systematic in that we needed to achieve 3 goals. We needed to define anatomical relationships between the nerve itself and the oral anatomy if we were going to put a device in onto the upper teeth. We then needed to demonstrate the feasibility of non-invasive stimulation. So with Inspire, they have the benefit that when the surgeon dissects down onto the hypoglossal nerve, they see the nerve there and they have a cuff electrode and they just put it on. Whereas we had to demonstrate that we could transfer the current across the mucosa and that it was non-inferior to doing an implant. And then the third thing was thereafter, using those data that we had grabbed from proving that out, to translate it into humans as a proof of concept and demonstrate that if we stimulate this nerve, we can open the airway up and improve airflow. So we got into the cadaver lab, and I did a variation of a transpalatal advancement flap, dissected down to the nerve, and started to define the relationships between the mucosa, the oral landmarks, the teeth, the hard palate junction, and then we did an extensive examination of CT imaging to validate that those, in higher volume, that those anatomic relationships that we were seeing actually existed in higher volumes. So that was the first step towards designing inputs, and this is where the engineering side comes in, gathering inputs that would become design inputs for the design of the device. We then wanted to prove that we could stimulate transmucosally at least a non-inferior rate to if you were to dissect down and put an implant on the nerve. So we designed an animal model, and we wanted to define this model to test the feasibility of transmucosal stimulation. We went to the pig model, which is the gold standard craniofacial oral and craniofacial preclinical model, and again, took out the knife and started dissecting out the nerves. We were able to identify a nerve that was equivalent to the lesser palatine nerve in pigs. The one thing that we didn't know was whether that nerve provided sensory or motor innervation. So we took sequential histology slides of the innervation of the nerve as it coursed back to the palate. We're able to confirm that it innervated the musculature. We're able to identify the muscles that it did innervate, and then use that as proof to say, well, now we just need to do this in a live setting in a pig, and demonstrate that transmucosal stimulation is equivalent to if we dissected down and directly stimulated the nerve. So you can see there, that's a photo of the nerve in the green circle, underlying the palatal mucosa, and a histology slide demonstrating the nerve encapsulated by its muscles. And so this is me, actually back home in the land down under. We executed this animal trial and did exactly that. So we were able to demonstrate exactly the outcomes we were going for. Namely, that we can achieve equivalent and non-inferior activation of the muscles by measuring the EMG in the muscles that the nerve innervates transmucosally by placing electrodes over the mucosa to that if we were to do an implant itself. And so with this proof, we went to the surgeons at Johns Hopkins, namely Dr. Kevin Motes and Dr. Pham in the Department of Sleep Medicine, and we said, how do we design a human model of disease to prove out this concept? And so we did exactly that. And we were lucky enough that they were already running a study that was very similar, and we were able to add on to that IRB to get some human data. So we designed these devices. We used thermoplastic polymer molds with electrodes embedded into it that sit over the position of the lesser palatine foramen. It was wired to an external pulse generator which provides the neurostimulation, the electrical current. And then we put patients to sleep with propofol sedation to imitate sleep, not perfectly the same as natural sleep, but an acceptable model. Stimulated got the patient into airflow limitation, stimulated the nerve, and then demonstrated the delta between the pre-stimulated and the stimulated state. And so here's some images from of the airway. So you can see this is an endoscope that goes through the nose and looks down the airway. You can see that the palate, as it stimulates, is coming forward. Let's see if I can do that again. You can see it fasciculating with the pulses of the electricity going through that nerve to open up the palatal airway. And then again, the side wall of the throat here, as we stimulate, you can see it moving out to the side. Now, the reason that that's important is because these are the two patterns that Inspire and these other tongue therapies can't treat. The palate flops backwards and the side walls of the throat collapse inwards. So we were able to demonstrate that from an anatomical point of view, but the question was, could we improve airflow? Sorry, that's the same images there. And the answer was yes. Very quickly, we were able to demonstrate that we could do such a thing. So this graph here shows an airflow tracing from a pneumotachometer or an airflow measurement device, as well as neurostimulation EMG tracing. So you can see quite reproducibly, we have airflow limited breaths, and then when we stimulate, we're able to boost the airflow and open up the airway to the same level as your therapeutic CPAP level, and sometimes better. And that was quite a reproducible result. So you can see on purpose, we left the patient unstimulated in between to be able to use that as a control. But you can see quite reproducibly, we're able to increase the flow. Here's another graph with an even higher magnitude of response. And so that was our proof of concept. To date, we've tested in 26 patients. These are the summary data from the patients we've tested in. So right now we're running on proof of concept human data that we can improve the airflow to the same level of CPAP or even greater in some instances. Our eventual vision for this, and this is where the AI component comes in, is that once this is in market and being prescribed, that we can incorporate sensing technology and capture data from the oral appliance that can be used to encourage the patient to continue to use it, positive reinforcement that yes, it's working, continue to use it, adherence and compliance being one of the major shortcomings of CPAP, as well as providing physiological data to the clinician that's prescribing the device so that they can see how they can titrate or change the therapy to optimize the effect and continue to track the health benefits of the patient. Eventually that system, our vision is that system will be closed loop. So the data that it captures will, outside of the device architecture, be run through an artificial intelligence model, which then automatically alters the neurostimulation parameters and the therapy to optimize effect over time. So it's a pleasure to be here and to present our work, and I'd welcome any questions. Thanks for your time.
Give the audience some feeling for how this fit into your master's degree education and the time frame during which, how many years ago did you start on this, and what's the pace?
Sure, yeah. So I started the Masters of Biomedical Engineering in 2022-23. During that period, we had identified the problem, hypothesized this approach, and then we had actually executed the animal study by the end of that 12 months. Very shortly thereafter, we had got our first patient and our first positive result. And then ever since, we've been continuing to build the data set. So very quickly, we got human proof of concept within a period of probably about 18 months. And now we're at the stage where we have enough that we're able to raise the necessary capital to continue to push the project forward.
Remarkable time frame for this kind of development. Yes, Dr. Zizik.
I'm fascinated, wonderful. What, 2
Thank you.
years. First, I saw you no arousal. I assumed that this is a subthreshold delivered signal, and I wasn't sure of the electrical parameters in terms of amplitude, what voltage and what frequency, how many hertz were you delivering at, et cetera. Could you elaborate a little bit on that?
Sure. So the best way to think about the neurostimulation is that right now, the levels at which we're getting efficacy and airflow improvement sit well below that of what wakes patients up during this procedure, but also during native sleep. So we've done some other natural sleep testing to identify that arousal threshold. And the efficacious amplitude sits probably 50% of what is required to clinically arouse the patient and wake them up. We have our own proprietary waveform, but what I can tell you is that the frequency is in the order of 100 hertz with a pulse width of between 100 to 200 microseconds. 100 hertz.
Is it monophasic signal?
It's a biphasic.
Negative or positive?
It's a biphasic square wave that alternates between the two. Yeah. So by using high frequency waveforms, what that does is enables us to create strong muscle contractions without sensory activation. The longer the more abruptly that you stimulate the nerve, the more sensory activation you get. So those very short, high-frequency dosed stimulations prevent that sensory threshold from being activated. Yeah.
There's a question in the back.
I wonder what the anticipated cost of this per patient will be when you are able to bring it to market. Sounds like a great idea.
Yeah. So we think that, to give you some context, CPAPs can be as cheap as $500 or as expensive as $3,000. and the Inspire device it goes up to $40,000 per patient. And so we think that we can hit a price point of between $5,000 and $6,000, which we validated with market discovery and priced according to the health economic value that we think that we can provide to insurers as well as to public payers.
Arthur?
What's the difference in the incidence of sleep apnea between genders?
That's a good question. It's predominantly male.
How predominant?
Off the top of my head, I think it's like 65%, but between 60 and 65%. Now, I think part of that is that our BMIs tend to be slightly higher. We have more bulk in the muscle than females do. But females certainly get it, and I've seen very, very severe sleep apnea in women.
Do you anticipate compliance differences between the genders?
I don't know. Actually. I'd love to go back to the CPAP data and have a look at that question. But what I can tell you is that in the CPAP literature, a lot of what we see is like willingness to accept the therapy in the first place is a strong predictor, and initial usage is a strong predictor of whether they continue to use it. So that's part of our strategy to target those who have failed CPAP, desperate for a therapy, and strongly counsel them and track them with this software system to enable to make sure that the use that they start with is the use that they continue with. Yeah.
Yes, sir.
I guess you could hear me from here.
Yep.
I'm a school of medicine grad in biomedical engineering, and very much interested in this area and have worked somewhat in this area. So my question is, in terms of endotypes for sleep apnea, do you have any idea of the efficacy across the board in the various endotypes?
Yes. So.
Why don't you repeat the question?
Sure. Yeah. So the question is, are there certain endotypes or phenotypes of sleep apnea which may benefit most from this therapy? So the answer is yes. And being an ENT surgeon, we think about the airway very much anatomically. So those anatomical phenotypes are very relevant. We think that patients without primary flow-limiting tongue-based obstruction are going to be the ones that benefit most from it. And that represents about 60% of all patients with sleep apnea. 40% have the tongue-based obstruction. But there is an opportunity for this therapy to be used as an adjunct to tongue-based therapies to achieve multi-level therapy.
Dr. Brodsky?
Quick follow-up, if you don't mind.
Oh, sorry.
Yep, sure. Yeah.
So we're looking at your stimulation of the nerve. When you compare the efficacy of this approach versus 8109, what are the key differences that you anticipate?
8109 being the drug that's coming to market for sleep apnea. Look, I think the data I've seen from the 8109 published trials is pretty good in terms of efficacy. One of the shortcomings that we see is that because of the mechanism of action, I think acting at the neuromuscular junction, we get some sleep quality related effects, pharmacologically induced sleep quality related effects, and arousal in some patients. So that, I guess that would be the shortcoming of those, but that's certainly a welcomed addition to the sleep surgeon or sleep physician's armamentarium of therapies that we can provide to the patients. And I would say that I'd caution people thinking about single therapies being panaceas for sleep apnea. I think each patient is different. Each patient's tolerability is different. What this therapy does and what that drug does is allow the sleep clinician to make an appropriate and clinically informed choice for the patient. Yeah.
Dr. Brodsky?
Yeah. Great work.
Thanks.
What type of registration trial do you anticipate having to do to satisfy the FDA?
Sure.
I mean, it's amazing where you've come already, but I'm just curious as to where you've gone.
Yeah, that's an excellent question. So in the device world, we're not restricted by phase 1, 2A, 2B, 3, etc. So we're sort of fortunate from a capital requirement and time requirement to get this to market. We think that we need to initially we'll do an early feasibility study under the breakthrough pathway to demonstrate initial safety and efficacy outcomes, and the N on that is about 20 patients. And then the pivotal will be an expansion of that with a total N of 72 patients based on our current sample size calculations. The design of that, it will be a prospective observational trial where we use the patient's pre-treatment sleep study as their control, and then look at the improvement over time for over a period of 3 to 6 months. Yeah.
Yes, ma'am.
Is the stimulation constant, or does it sense when the airway is obstructed?
Good question. It's phasic, so it's not.
Repeat the question.
Yeah, sorry. The question is the stimulation constant, or does it respond to obstruction? So the stimulation is phasic in that it stimulates only when the patient's breathing in. There are two modalities that we're using to employ that. The first one is that if there's another company from Belgium that has a hypoglossal nerve stimulation device that's demonstrated that if you take data from the sleep study and use that to program the frequency of stimulation based on that in the different phases of sleep, then you can get up between 75 and 80% of the breaths covered by planning, as well as a phenomenon called phase matching, where the patient's respiratory rate will match to the frequency of the stimulation, because it's less effort to breathe during the stimulated period than it is to struggle against the apnea. So that's the first thing that we'll use. And then in the second generation of device with the sensing technology, we'll eventually have closed loop input, where the sensing technology will be able to demonstrate, so we'll be able to sense inspiration and airflow obstruction and then respond to that to increase that capture.
Last question, Dr. Anderson.
I just wondered does it cause any sensation at all? Could there be some discomfort that causes partial arousal?
Good question. So the question is, does it cause discomfort or partial arousal? Off the record, I've tried this device both awake and asleep, and so I can talk to my experience with that. And the way I can describe it is that it feels like a tapping on the palate. It's not uncomfortable or painful at all. It's just a strange sensation initially that quite quickly you become used to. As the amplitude goes up, you can feel the muscles contract, but it doesn't cause gag and it doesn't cause pain. One thing that we do need to be careful with is there's a nerve close to the lesser palatine nerve called the greater palatine nerve, which provides sensory information to the teeth. And if you bring the electrode too far anterior, you can hit that and get tooth pain. But we've been able to establish a system whereby we can place the electrodes without doing that. So that's the awake experience. And then the sleeping experience, we're working to get more data around non-clinically obvious arousals in terms of movements, etc. In natural sleep. That's our next study to assess whether there's any disruption to the sleep quality. Yeah.
Thank you very much, Dr. Sideris.
Of course, yeah.
I think everybody who knows me well knows what I do in my spare time as being retired is I hang around the licensing and patenting office of Johns Hopkins, and every once in a while I find a project like this that is absolutely stimulating and has its root in solid thinking and truly remarkable human experimentation under safe conditions and in the real world environment. Finally, let me just say that for the members of the class of 65, they know already what I'm going to say. But for those who are not members of the class of 65 in this fine audience, I want you to notice on your way out the sign on this auditorium that says Evelyn and Barry Strouch Auditorium. Dr. Strouch was a member of the class of 65, my roommate during medical school, and a dear friend throughout his whole career. He became head of medicine at Fairfax Hospital in Northern Virginia, and he was always felt very clearly that his being chair of medicine at Fairfax Hospital was competitive with my being chair of medicine at Johns Hopkins, but I never told him that wasn't true. So thank you all for coming. I think we have here the largest audience in the retreat, at least that I have seen, the reunion that I've seen. And it's been just a pleasure putting this program together and having you attending. I have not seen anybody leave. You know, it's a Johns Hopkins tradition that if you don't like something, you leave the auditorium, but I saw nobody leave the auditorium today. So thank you all very much.